And so we often have this debate on what is there for this balance. Are we really saying that a slice of bread that is whole grain, that is fortified, possibly with calcium, possibly with some iron, some of them have vitamin D, is not good for you? So I think for us, I think most of us are working in pediatric nutrition have a much more balanced view.
Welcome back to the Into Place Therapy podcast. Today, I'm joined by Professor Rosan Meyer, who is a leading specialist in pediatric nutrition and feeding. Rosan teaches at the university level internationally and has also held roles at leading hospitals and institutions in the UK. Her current practice in London focuses on food hypersensitivity, feeding difficulties, and avoidant restrictive food intake disorder, or ARFID. She's also deeply engaged in research and serves as a trustee for ARFID Awareness UK, which is a charity I've featured in a previous episode. Rosan brings a wealth of knowledge and advocacy to our conversation today on children's feeding challenges. So, Rosan, I'm very excited to have you here today and to learn from your experience.
Thanks for having me, Isabel. You've kind of invited me on one of my favorite topics, so it's really a pleasure to be here.
Perfect. So to get started, I'd love to hear what drew you to focus on children's nutrition, since it is one of your favorite topics, and feeding challenges.
It's a great question. So as you can hear from my accent, I am South African. So it was really me moving to the UK and being thrown into pediatrics within a hospital setting in London that I fell in love with the topic. I was lead of the feeding team. So we have, in other countries, feeding teams within a hospital setting for many years there. But I think what really drew me to the topic is that without feeding, a child does not grow. And it's not only about the science of nutrition, so macro and micronutrients, but it's one area where there's a psychological link to it, and every person, not only children, to survive has to eat. And you can see from birth this intricate link between parents, not just the mother, and a child's nutrition. It's not only an emotional link, it's the concern for a child's well-being, because of course, initially when a child is a baby, you don't survive without that nutrition. And then as a child develops, it becomes more than just survival. It becomes a part of development. And these intricacies around enjoyment, physiological well-being is part of why I'm so interested. And then, of course, I migrated into a lot of the pathology, so food allergy, neurodevelopmental disorders. And this part of where can it go wrong intrigued me. And most importantly, the absolute despair from parents if it goes wrong. And for me, that is really what drives my involvement, is the despair that parents are experiencing, and really somebody just to listen and help them.
Yeah, I mean, it's really important work. And from a lot of the parents I've spoken to who have children with, feeding challenges, there's so much frustration, and it's such a long process to get help and support. Yeah. And so, I'm again really glad that you're out there doing this. And so, speaking of parents, what are some of the most common worries that you hear from parents about their child's eating?
Absolutely. So first of all, Isabel, you have to understand there's a spectrum of worries. At the simplest kind of spectrum of worry is my child dislikes my cooking and really spits the food out that I'm cooking. How can I improve that? And then you can get what I say, from mild aversive eating to the more moderate. My child is no green foods, for example, and whole categories are being avoided, to the more severe spectrum where it's not just categories, it's foods per se, and you might just have 5 or 6 safe foods. I think what most parents need to know, and hopefully that listen to this podcast, is that having feeding difficulties is pretty common. So spicking food out and having some extended time, and a mom or father that cooks a meal and they don't like the meal, and having an extended meal time is pretty common. So along the course of having a child. What is not common is when this persists, and also if it is not just a couple of foods, but really a lot of food categories. And meal times become really a time that parents are dreading. And that is when foods are not just spat out, but it takes an hour to feed them and becomes a drag. So I would say what is common is my child dislikes a couple of foods. Sometimes meals are a bit disruptive. They throw the foods. Those are very common complaints. What is not common is that a mealtime goes to an hour, and it's not just a couple of foods. It's big categories of they don't want meat, they don't want vegetables, and it's really a difficult time around meals.
And, with that piece, I appreciate that you kind of broke down the difference between what is picky eating that isn't necessarily concerning and something that's more serious.
Yeah,
Because,
but I love that you're bringing up the picky eating, because I'd like to kind of just discuss that a little bit further, because it is a topic that occupies me. So a lot of parents come picky eating, but did you realize that there are about 12 different terms that can be used? It's picky eating, fussy eater as well, aversive eater, food avoidance, and the worst for me is behavioral feeding difficulty, or just feeding difficulty. And I think here an important message to the parent is that from a scientific perspective, yes, we have a definition for each, but the definitions overlap between what is a picky eater, what's a fussy eater, what is feeding difficulties, what is aversive eating. For me, the most important is how it impacts on the child's life and the parent's life. Whether you say it's a picky eater or it's a fussy eater or anything else, it's really that terminology. We can argue it. It's not so important. It's really the impact on the parents. Because for me, for example, if you said to me, if I get a referral letter and saying this child has got a behavioral feeding difficulty, and it's a 2-year-old, then I'm going to say to you, I'm going to challenge that, because behavior means the child is behaving badly. But most of the children, there's a journey towards that. If it's, for example, if a child was refluxing as a baby and has been learning how to avoid food, then I would say, actually, that's not a behavior. That's a learned eating pattern because it was driven by discomfort. So the terminology is a little bit of a difficult aspect for somebody like me that works in the research, because there's something like a pediatric feeding disorder as well, which has got a much more stricter criteria. You initially mentioned that I'm part of ARFID, which has got avoidant restrictive food intake disorder, has got a very strict criteria. But I think an important message to all of the parents is really, what is the impact on you? What is the impact on the child? Irrespective of the terminology that's being used.
yeah, I really appreciate that as a therapist of looking more, what are the symptoms and what is the impact on functioning, rather than getting caught up in a diagnosis, because it doesn't allow us that flexibility.
Exactly. And depending on which healthcare system you work in, often a specific terminology actually opens then a door
Yeah.
And that makes it really difficult for me as a therapist, is that often I have to give a very specific word, pediatric feeding disorder. Child might not be really fitting it, or avoidant restricted food intake disorder, so that it opens up the therapy, or that you get the healthcare system to pay. But I often find it really not useful because it doesn't reflect that impact on quality of life on both child and the family. And it treats it almost like an entity that is standalone without the acknowledgement of how severe or that impact is.
Yeah, and that's a sign of an excellent provider, which you clearly are, of that sort of moving between both what the insurance needs are or the research piece. I know you're very involved in research, and then
Actually
but
The
working.
most importantly, the parents and the
Yes.
child.
Yep.
centering them. Absolutely. And is there, kind of zooming out, is there a myth or a misunderstanding about childhood nutrition or food allergies that you'd like to correct on this platform?
It's a very big question. I almost want to kind of split in two and saying let's talk about the childhood nutrition versus food allergy. In terms of the myth that I often get in terms of childhood nutrition, in particular around the fact that social media is part of our life, Dr. Google is part of our life, is that most of the children's consumption is much better than what the parents think it is. And I think, let me make it practical, because a parent, especially if we think about the context of feeding challenges, parent would come to me and saying, "Oh, Roseanne, my child is not having asparagus and Jerusalem artichokes and all of these really fancy foods that social media is creating a demand that the child is having to have all of these chia seeds and all of those type of things." So often, I would say the biggest myth is that a child is often doing much better than what the parents think they're doing, because your measure of what is doing well is do they have a protein, a carbohydrate, fruit or vegetable with every meal, and snacks with fruit and vegetables, and as simple as possible. What I mean by that is trying not to have it as processed as possible. And if you have a child that has peas and a banana and apple and pear, really simple foods, and in the UK it's oat porridge. In the US, I could imagine it's grits, and you have bread. So you have two or three different carbohydrates: a pasta, a bread, a rice, and a maize or a oat. They have already then a variety of different grains and two or three different proteins. So I think that's the first myth, is that they're most probably doing better than what you think they're doing. In regards to food allergy, the most common myth that I have is first of all, is that there's this, what is an intolerance versus a food allergy? So, of course, very big difference. A food allergy is an immune-mediated response that is repeatable. And the myth here is that in infants, that a non-IgE-mediated allergy is a food intolerance. And that's not the case. A food intolerance is not a non-IgE-mediated allergy. Food intolerance is really where it's not immune mediated. So classical example is lactose intolerance versus cow's milk allergy. So I think there are these myths, and you and me can talk a whole day around that. But I see, for me, if those messages come across and saying you're most probably doing better than you think you're doing, and that food allergies are not food intolerances, and possibly I throw in that actually food allergies are not as common as it's thought people think it is.
And, two things there. I appreciate that you split those up. And, the first one is you're touching in there on sort of the pressure on parents to be the perfect parent and, given the perfect diet. And so, that can be a very shame-inducing for families, or frustrating, or I'm not good enough, or not doing well enough. And, I imagine you see that. And how do you support parents? Right.
No, that's a great one. Look, first of all, I want to kind of say, I'm doing a podcast because I'm thinking that nutritional care is a triangular care. What I mean is that it's the healthcare professional, it's the parent, and then it's social media and the internet. Okay, and what social media and internet creates that pressure, but it's also great. So the first aspect is to manage the access and to simplify it. And normally what I do is try to reduce the pressure by, as I already mentioned, just giving some very simple rules. And rules sound very strict, but it's not as strict as what I'm trying for it to be, is to create what a meal looks like. And so we've spoken about the protein, the carbohydrate, the fruit and vegetables. And then I individualize it. What I mean by that is I look at what the child has already, and then we move it into those categories to make it realistic, to reduce that pressure, because many parents want more. That's not good enough. I want them to have all of these other new foods. And I've seen on social media, they're supposed to have, a curry. My child doesn't want a curry. And they're supposed to have hummus, but they don't want to have hummus. But they'll have chickpeas, for example. So it's simplifying that. And then I look at the whole day and simplify it even more, because you might have a parent that says to you, look, Rosan, my child does not want to have fruit for breakfast, but we'll have a fruit for a snack. And they might not have a milk product like a yogurt to meet their calcium requirements within their meal, but they will have it as a snack or as a dessert. So they might have a yogurt as a dessert. So it's trying to manage the nutritional requirements and dividing it up into a day. And instead of saying this traditional, you need to meet all of it in one meal, we split it up and saying, okay, maybe doesn't want it at breakfast or at lunch, but we can bring it in as a snack. So you meet the requirements in a way that is accessible to the parents and the demands of a parent. And I think that's, for me, really important, is to acknowledge that we have the pressures from social media to use for ideas and what it's useful. And I run my own Instagram there as well to provide ideas, but to reduce the pressure there. And I think the reduction of pressure has then the positive impact once a child realizes that the parent is more relaxed because there's not this demand, you have to try this, you have to try this. Then the child also relaxes, and that pushback around trying new foods is not there. Because the pushback is normal. I want to be autonomous. I want to make my own choice. And if the parents then push, then there will be that pushback.
And with that too, of like being flexible on the choices and meeting the child where they're at, can you speak a bit about like processed food, right? If the child is open to that and not necessarily other foods that, the parent thinks they should be.
Yeah, and Isabel, as you know, it's a very hot topic, Yeah. So I'm going to first of all, again, say from a research perspective, and I collaborate a lot, you will find me looking at the immune modulatory role of processed foods, and particularly thinking about children with allergies. That doesn't, not just food allergies, but also asthma, eczema, all of those. And the research is pretty clear that having ultra-processed foods has a negative impact on the immune system. But I'm also very pragmatic here to say that the definition of ultra-processed foods often puts the parents into a difficult position. And let me give you an example here. Whole grain bread. If I buy the sliced whole grain bread, I can tell you, I know the American brands, I know the UK brand, you will find that they will be classified as ultra-processed foods. And if you go then saying, okay, Rosanna, I'm going to, then what would be not ultra-processed foods would be, let's say, a really bakery sourdough bread would be not going for ultra-processed foods. But the price difference is huge. And so we often have this debate on what is there for this balance. Are we really saying that a slice of bread that is whole grain, that is fortified, possibly with calcium, possibly with some iron, some of them have vitamin D, is not good for you. So I think for us, I think most of us are working in pediatric nutrition have a much more balanced view to say ultra processed we see as high sugar. So, and that includes also the ready-made food pouches that you have. They are, I can't get away from it. They are very high in sugar. So, and that is, we are working with companies to bring that down. Second thing is biscuits, crisps, all of those very high salt, very high sweet foods, and then your foods that are takeaway foods, where they use these ultra processed foods. Those are the ones that you'd want to keep as low as possible. So when you go and home foods, and my advisors normally have it as simple as possible. So if you have a piece of fruit, just give the piece of fruit. And if you can, don't buy ready-made foods because they will be ultra processed. But if you cannot avoid them, then of course beggars can't be choosers. Then try to not have it as high in sugar content, salt content, especially for the younger ones. I also try to stay away from nitrates, smoked foods, or if you buy bacon, have the nitrate-free bacon. So I think a balanced approach is the desirable. So as clean as possible, and as low in sugar as possible and salt as possible, and really having a pragmatic approach around it. But I acknowledge it's difficult for many families because I think the more cleaner it often goes, the more expensive it goes.
And I appreciate that perspective too, because it's acknowledging, the real life limitations or barriers.
And Isabel, I mean, I'm not working in every country. I work in a couple of European countries and in the UK. But the sad aspect is processed foods often, if I take the example of a sausage in the UK, okay, we get a sausage, you can sometimes get a 1 pound pack that has 6 sausages, but the actual meat content is about 50%, and the rest is fillers, whether that is wheat fillers and all kinds of additions. But that often is what is affordable. And I think the challenge really for us working in healthcare is to be putting pressure on our governments to really make healthy foods more affordable, and the education around what is seasonal. It is often not as clear. I live in a European country. Banana is certainly not something that is seasonal for us as well, but it's commonly available. But for example, apples, winter seasonal, oranges, but that's not obvious to many families, and it's seasonal and it's cheaper. So I want to acknowledge that certainly for us, we see food insecurity going up. And food insecurity also means it drives ultra processed foods, because those, if you go food banks and get supplies from food banks, it would be ultra processed foods a lot of times.
And I appreciate that perspective as a social worker of, this is also taking that off families and going, these are systemic issues that are part of this.
Absolutely. Absolutely. And at all times, and I think that's something, the onus on us as healthcare professionals would be to be mindful of the socioeconomic situation that we're dealing with our families.
And, I'm curious, like we talked about processed foods, and how about these plant-based diets or the dairy-free diets that we're seeing all over the place?
Yeah, no, it's a great question.
Yeah, what should parents keep in mind with those?
So, I would say the most important aspect to keep in mind is that if you were, the vast majority of them would be classified as ultra processed. Okay, we can't get away. though, the reason that they're ultra processed is that they have additions. For example, if I use calcium as an addition in a plant-based beverage, um, you need to have stabilizers so that actually it's stable within the product. So therefore, a lot of times you would get a lecithin or a gum added to it. So whilst there's the processing factor there, there is this weighing up that it delivers also calcium. So if you said to me, Roseanne, would you go for an organic plant-based beverage that has nothing added to it versus a beverage that has additions like calcium, iodine, vitamin D? I would still, if I saw a child in my allergy clinic, say to you, I prefer a fortified brand versus an unfortified. There's a but. There are better brands than other brands. For example, I would then prefer one that's unsweetened. So you absolutely get unsweetened brands that are fortified that are better than other brands. You can also get brands that don't have these gums added but are still fortified. So I think the first aspect here would be if you go for plant-based, let's say beverage, I would still go for a fortified one. Second aspect, if you go for a plant-based beverage specific, you need to consider the protein content. So naturally, a coconut is not high in protein. So, if you go for coconut milk, it's not naturally high in protein. So it is not that it just replaces your cow's milk, because cow's milk is very high in protein. If you then have the protein added, you can see my problem. It becomes an ultra processed food, because then it might be often with a fava bean or a pea protein. So then it becomes a processed food. I think if you go for plant-based protein sources, let's say a burger, a patty, or any of those plant-based yogurts, of course, we are looking at exactly the same question. Is it becomes an ultra-processed food, and what is your nutritional benefit versus the fact that it's ultra-processed? So if parents listen to this and they're saying, "Look, I want to be plant-based," then we advocate for a whole food plant-based diet rather than an ultra-processed one. So it means going for your beans, going for your lentils, rather than a patty that has been ultra-processed, or a vegan bacon that would be ultra-processed. So go for the whole food rather than the processed foods. So I think that is important to keep in mind.
Yeah, there's so much misinformation out there. So I appreciate also that nuance of there's no good or bad or right or wrong. But there is.
Yes, because, I get these emails from parents saying to me, Roseanne, I read everything about these plant-based milks, but forgetting that their children might have pouches of fruit pouches, or, might get one of those snack bars that are healthy for children, and then honing in on just the plant-based beverage. At the end, it is the whole diet and not an individual product that one needs to consider. So I think that holistic approach is much more important. So if I had an allergic child, for example, cow's milk allergy, I would first say, let's look at the diet, keep that beverage in, that's calcium fortified and vitamin D fortified. First, look at the cleanness of the diet itself before I kind of saying, let's take out that beverage. Or at the end, if I were to go to saying, okay, I'm going to add a supplement, you and me both know gummies, liquid that have got mannitol, sorbitol, xylitol, or sucrose, or saccharin in there. Again, stabilizers. So, you always need to think, okay, what am I winning at the end? If I'm splitting it all out, then I need to fortify. And what do I fortify with?
And since you mentioned, cow's milk and dairy, I follow you on social media, and so I saw you posted something about the milk ladder, and it looked very fun. So I'd love if you could just share, what that is and how you use it in your practice.
I'm glad that you're following me, Isabel. I think the first thing to say is the milk ladder we use for children with a diagnosed cow's milk allergy. And when we developed the ladder in the past, so the origin of the first ladder was in the UK, it was really meant for the non-IgE mediated cow's milk allergy. What I mean by that, it's the delayed type cow's milk allergy where you don't have the risk of a more severe reaction. So you don't have the swelling, you don't have the immediate type rashes. But in recent years, it has migrated towards the use of also in the more immediate type cow's milk allergy. So what is a ladder? Ladder is really based on that you start with foods that are baked and contain cow's milk, and the baking process denatures some of the protein. So we always say it changes from a protein that looks like that and stretches, it out. So it looks in particular with the conformational epitopes that makes a difference. So it means it changes the allergenicity, it reduces it. So if you go from baking, then going and baking less, let's say, for example, in a pancake, going to a mature cheese, to going to a yogurt. So you can see I'm going from highly heated in a recipe to less heated, to going fermented but still pasteurized, then just fermented, i.e. like in the yogurt, with a short pasteurization, and then finally milk. And as you go step up the ladder, you go least allergenicity to most allergenic, which would be your cow's milk. And I hope the message here is that it is not something you would just be doing by yourself. It's something that should really be guided, ideally by a dietitian that works in allergy, because every dose and every step of the ladder is not only baked in a different way or processed in a different way, it has a different protein content. So we start with a small amount baked and then go up a high amount baked. And so you really want somebody to guide you through that stepwise approach. And the objective here is that we have a way to introduce cow's milk at home that is bringing tolerance earlier for the IgE-mediated allergy, and for non-IgE-mediated allergies, the way to introduce it at home without also having constant visits to a doctor and improve the quality of life for a child.
Yeah, I mean, that's fascinating, first of all. And, I like that piece too of kind of the collaborating with families and giving families a sense of, direction and a role in that.
Absolutely. And I think in all nutritional practices, look, I hope in all medical practices, it is we involve our families and our parents into the care. As I said to you, it's a triangular service that I believe we should be providing, where parents come back and saying, I've done my reading as well. What is that? Can you tell me about the ladder? Can we tell me about picky eating? Or can you tell me about vitamins and minerals? And so that shared decision making is critical for me.
And, thinking about families who are, have a child who maybe isn't growing as expected, how do you balance like addressing the nutritional needs without making food feel like a stressful topic?
Such a great question. I want to first acknowledge to anybody listening is that a child not growing, and in particular a child not growing and eating well, has been shown to be extremely stressful and anxiety provoking for parents. Because if a child is not growing, there is that perception it's me as a parent not achieving an objective. Because the primary objective for me is my child should be healthy, should be growing, all of those things. And that's why I also want to say is we've moved away from using the word failure to thrive. We use faltering growth. Because failure to thrive implies that there's a failure of parenting. So we don't use that term anymore. So I think the way I always go by and say to the parents, it's my role as a dietitian to take the responsibility for a child achieving their requirements in a way that is achievable for the parents without increasing the stress. And so what I normally do is within a dietary history, I find the positives, because all children, it doesn't matter, even if a child has got an ARFID-like eating where they only have 5 or 6 weeks, there's always something positive. So within those positive areas of eating, it's often a question of simply increasing the foods and also changing the ratio. What I mean by that, it might be that a meal is just carbohydrate rich and you need to introduce more fat and a little bit more protein. It can also be a question of finding a food that is sensory-wise accepted. So let me give you an example. My child only wants pancake for breakfast. Doesn't want any protein source, just pancake. And whilst there is egg in a pancake, then I would, for example, say, okay, we can boost protein content by changing the type of flour we add. So it's still the same base. So we change, for example, a third of the flour is almond flour. That's, of course, in a non-allergic chart. Or we add to the flour a pea flour, something like that. So what I try to do is provide solutions that I know would be successful and not make it, because I can provide a printed sheet to say your child needs to eat more and you need to introduce more fish and meat, and the child might not be eating that. So I think the way I try to reduce the stress is by introducing foods that I know are more likely to be successful. The second and important part of it is I try to figure out what the origin of the faltering growth is. And it's often, it's not just energy, protein. It can also be that some micronutrient that is missing. There are some micronutrients, zinc, for example, that impact height growth. So you can have a child that is zinc deficient, or it might be that a child has got excessive losses. They might still be vomiting and having diarrhea. So whilst I get a referral saying just increase the nutrient intake, it might be actually a question of losses. So it's sometimes really these small little changes. So I would say I mitigate the stress by finding suitable alternatives that are within the sensory accepted range, and I provide micronutrient supplementation also within a sensory accepted range. And that's really important for me, that it is, again, this is shared decision making, that a parent says to me, Rosan, no, I don't think my child will have it. If a child only has crispy beige brown foods, then I provide alternatives that are nutrient dense, that are crispy beige brown. The fact that we want green and red and orange foods, that's a long-term objective. The short-term objective is let's just optimize nutrients so that growth is improved.
And I love that because, you mentioned the psychological perspective when we started out, and that's in many ways, I think, centering the child-parent relationship too, which is obviously a huge part of development.
And Isabel, here, I think, I would collaborate with people like you. I would collaborate with my psychology team, or if there's a sensory issue, I have occupational therapy and speech pathologists that are, but, I'm by no means selling myself as a one-stop shop. It is really figuring out, but certainly I try from a nutritional perspective, not to be a person that lays blame on a parent. Most parents have enough self-blame. It's more about kind of saying, okay, I so acknowledge that it's difficult, and reduce that stress of growth if we focus on that question. But it's something applied to all nutrition-related questions for parents, is that it's the blame that you want to reduce and that anxiety.
Yeah, and that anxiety in the home that impacts the child, or, the power struggle of, forcing something that isn't working, which is exhausting for everyone. And again, so it hits.
Exactly. And it's sometimes also having that discussion to say, that's not a battle we're fighting. Sorry, I'm just recovering from a cold. So,
Oh,
but I
no
think
worries.
it's really important to these difficulties that parents are describing at home with meal times and so on. And I want to touch here on distractions because traditionally, as a dietitian, I would say no video, no iPad, no book, and so on. But, sometimes it means that anxiety comes down. So I often have a discussion with parents and saying, look, I know you've got an iPad there. So let's first improve the food variety or get the growth improved. And then we work on weaning off the iPad. It's really making the decision on what are the nutritional objectives rather than ticking all of these lists off and saying a child should not have any distractions, mealtime should be less than 30 minutes, and all of those things. There should be fruit and vegetables. If you don't achieve many of those, then me expecting that of a parent makes it unachievable.
Yeah, picking what the priority is and letting parents not have to be stretching themselves through.
Absolutely. Absolutely.
So for parents or professionals who are listening, what's a message that you'd want them to walk away with after hearing this conversation?
So I think for parents, I think my most important message is, first of all, is that you most probably are doing better than what you think you are doing. And to be kind to yourself in regards to achieving everything. Appreciate what you're achieving. Don't try to achieve all at once. For healthcare professional, I think the most important message is a very simple one, and that's just listening to what parents have got to say to you. I think the role of listening, I have a lot of times as a healthcare professional, I'm in a situation where I'm kind of thinking, gosh, I'm not sure how I help this family. But that's, I'm very honest and just listen and say to parents, look, I'm not quite sure. But the simple act of listening can sometimes make such a huge difference for a parent. So that would be my most important message to any healthcare professional, is just the act of listening.
Yeah, and it can be such a lonely experience. And so just having that person who's present and witnessing, can be really powerful.
I think the most important feedback I've had, and you mentioned that I work for ARFID, or I'm a trustee for ARFID Awareness, a charity. The most important feedback we get from parents of children with avoidant restrictive food intake disorder is that one healthcare professional that listened to them, and just the act of listening that made a difference to the families, that they felt listened to and being taken serious.
Well, I have so many more questions for you. So it's really great to hear all of this expertise that you have. And to finish up, could you share a little bit about what you're currently up to in your work, or what you'd like to highlight, since I know you're up to many things?
Yes. So I think the most important things to highlight outside of, like I said, I've already wanted to direct people to say, go to the charities, including ARFID Awareness UK. I think so. I'm setting, I've got group sessions for toddlers between 1 and 4, of parents that have toddlers that just have got feeding difficulties and don't want to eat. And so, if there are any parents that want to join those group sessions, we limit it to 8 parents just in those group sessions, and we have a lot of material, and I run it with a psychologist colleague. So it's really just aimed at those families that are struggling with a toddler that doesn't want to eat. I think also other work that we're doing is really around allergies, and hoping to get more information around breastfeeding support around food allergy. And I'll be circulating surveys around, and that's more research. But I thank you also for giving me the opportunity to share what I'm up to. It's always nice to have parents' opinion, and that's why I'm really motivated to continue a lot of the research areas around parental work as well.
Well, Rosan, you're a huge resource to all of us and to families. And so, yeah, I really want to thank you for the work you do and all your contributions on all levels, research, policy, the community, and then obviously to families. It's huge.
Thank you for giving me the opportunity.
Of course, and I'd love to have you back on at some point. And for those listening, I'll link to ARFID Awareness UK and Rosan's work in the show notes if you'd like to learn more. And as always, thank you for tuning in to the Into Place Therapy podcast, and I'll see you next time.